Morning. Oh, selamat sore.
Yeah.
Good morning. Oh, good afternoon. It's good afternoon.
Mau pakai diskon 20, diskon 50 ya? Yang itu template-nya, pakai baru. Pakai dulu. Kayaknya mau jalan itu diskon 50.
Okay, seems like all the panelists and already arrived in our Zoom meet. Will wait. Please kindly use our virtual background for our participant. I will send it to the chat. Good afternoon and welcome to the Radiation Oncology webinar series focusing on oropharyngeal cancer. I'm Iga, your host for today's session. First, a big welcome to our speaker, Professor Hans Kanders. It's truly an honor to have you share your expertise with us today. We are also excited to have Dr. Henry Kodrat, radiation oncologist, and Dr. Wigati Damiati, radiation oncologist, joining us today as our panelists. Welcome, Doctor. We can wait to hear your valuable experience on today's discussion. Also, welcome to our moderator, Dr. Seize Edwina Yanuarta, radiation oncologist. Thanks for guiding us through today's session. We'd like to extend our sincere thanks to our audience today. Please don't hesitate to send your question to the chat box. Today, we will dive into the latest research, treatment option, and field advancement for oropharyngeal cancer. Before we begin our session, let's capture this moment with a quick photo session. Please open your video and don't forget to smile. Dr. Hannah, can you help me?
Okay. For all the audience, please open your camera and use the virtual background. I will take photos. We don't know in which slides we are, so please open your camera. Okay, for the first slide, 1, 2, 3. For the second slide, 1, 2, 3. For the third slide, 1, 2, 3. Okay, thank you.
Thank you, Dr. Hana. Without further delay, it's time to hand over the session to our moderator, Dr. Seize.
Okay, thank you, Ega, for the kind introduction. Good morning, Prof. Kanders, and good afternoon, Dr. Wigati. Good afternoon to Dr. Hendrik Kodrat. Yeah. Good afternoon, everyone in Indonesia, and good morning in Netherlands, and welcome to the Radiation Oncology webinar series with the topic is oropharyngeal cancer. This webinar is still a collaboration between the Radiology Department of Gajah Mada University, Sarjito General Hospital, Indonesian Radiation Oncology Society or IROS, and with Anthony van Leeuwenhoek National Cancer Institute. My name is Seize, and I'm honored to serve as your moderator for this session. Today's session will feature a main presentation by one of our distinguished experts, followed by a panel discussion with two esteemed panelists who bring complementary perspective from their respective specialties, and also maybe a question or comment from the participants. It is an honor to introduce our speaker today, Professor Johannes Kanders, a leading expert in head and neck radiation oncology from Radboud University Medical Center, Nijmegen, the Netherlands. Prof. Kanders completed his clinical fellowship at the MD Anderson Cancer Center and currently serves as Professor of Translational Radiation Oncology at Radboud University. We are also honored to be joined today by Dr. Hendrik Kodrat, a prominent radiation oncologist from Dr. Cipto Mangun Hospital, Jakarta, Indonesia. And joining us as our in today's session by asking question or sharing your through the Q&A box or through the chat box. So without further ado, we start with presentation from Prof. Kanders. Please, the floor is yours, Prof.
Thank you for your kind introduction. And also thank you, Ega and Judy, for organizing this. So I was asked to give a lecture this day on oropharyngeal carcinoma. Feel free to ask questions. And maybe Ega or Judy, you can keep an eye on the chat box and don't hesitate to interrupt me if there are any questions you think that are relevant for the presentation. So I will start sharing my screen with you. Let me see. You see my screen?
Not yet, Prof.
Not yet, I think. I think there is a problem with the share screen.
And help.
Oh, yeah.
You see the
Okay.
screen?
Yes, the screen is.
Yeah.
Ja,
We
we
can see
zien
that.
het hoor,
I
Hans.
can.
Ja.
And you see it in presentation mode now?
Yes,
Yes, we
yes,
can
as
see your
well.
screen.
Ja.
Yes. Okay. Sorry for this, but I think we're all set now. So as I said, I was asked to give you a lecture on oropharyngeal cancer. I in maybe, as you know, in Jakarta, where we gave an astro course. There was also topics on head and neck cancer. And maybe some of you were there and have seen also part of this lecture. I'm sorry for that. But I added also new items for from recent literature. So I hope it will be interesting for you. And again, if you have any questions, please interrupt me. So a very important driver for oropharyngeal carcinoma, apart from, of course, smoking and alcohol, is HPV. And the HPV virus, when it is integrated in the ghost genome, produces two oncoproteins, E6 and E7. And these oncoproteins, they inhibit the E6 protein, disrupts the p53 pathway, and the E7 protein disrupts the retinoblastoma pathway. And both these pathways control the cell cycle. So disruption causes disruption of the cell cycle, which can cause uncontrolled proliferation. A side effect of the inhibition of the retinoblastoma pathway is upregulation of P16. And P16, therefore, can be considered as a surrogate biomarker of HPV associated oropharynx carcinoma. These are 4 examples of P16 staining. In the left upper corner, you see a very clearly positive tumor. The brown staining is immunohistochemical staining for HPV. On the right upper panel, you see a less intense staining, but still you see brown staining both in the nuclei of cells and also in the cytoplasm. And this tumor should also be considered P16 positive. In the left lower corner, you see staining, but mostly in the nuclei and not so much in the cytoplasm. And in the right lower corner, you see the opposite. You see staining mostly in the cytoplasm and not so much in the nuclei. And these lower tumors are debatable in terms of HPV association. Most pathologists consider a tumor P16 positive if more than 70% of the cells stains positive, both cytoplasmic and nuclear. And if you do then, for example, polymerase chain reaction or in situ hybridization, which are the gold standard for HPV expression, then you will see that in a good number there is concordance. So P16 and both PCR can be positive or they can be both negative. If they are both positive, it indicates a good prognosis, and if they are both negative, it indicates a poor prognosis. But there are also situations when there is discordance between the two, and there is indications now that this indicates an intermediate prognosis. But currently, the gold standard remains PCR or in situ hybridization. Sorry. This is a typical MR image from a patient with an HPV-associated oropharynx carcinoma. You see a fairly large tumor in the left tonsillar area with large cystic nodes in the neck, and this is typical for HPV-associated oropharynx carcinoma. They make very often large lymph node metastasis with a large necrotic center. The incidence of oropharyngeal carcinoma has increased in many countries, at least in Western countries. And this is mostly because of the HPV, one could say, epidemic. The increase in oropharynx carcinomas is mostly on account of the HPV associated tumors. And you can see here a somewhat older picture from Denmark showing that the incidence of larynx carcinoma is roughly stable, whereas from the early 90s, there is a steep increase in oropharynx carcinoma. We see that also in the Netherlands, and in many other countries, it is the same pattern. And we also know now that the major prognostic factor for oropharyngeal carcinoma is HPV status. And then in the second place, it is smoking status. And only in the third place, it is the TNM stage. So if you have a P16 positive tumor in a non-smoker or a person that smokes very little, you have in general a low-risk tumor. It means that this patient will have a fairly good prognosis with good overall survival. Whereas if you have a P16 negative tumor in a smoker, then, and also if this patient has an advanced T stage, then you have a high-risk tumor with a much worse overall survival rate. There is some good news. This is from the United States, where they started HPV vaccinations around 2005, 2006. And they now start to see, after 20 years of vaccination policies, they now start to see a start of a decline in the incidence of HPV-related oropharynx carcinoma. They first saw it in very young patients. These are, of course, very young patients, and the incidence in this age group, of course, is very low. But already they started to see, several years after the start of vaccination, a decrease in oropharynx carcinomas. And now, more recently, they also start to see a decline in older patients. I want to start now with a case. And I will ask you to answer a few questions that I have for you. And I will see, I have a voting system. We will see if it works. I'm not sure, but we just try and see how it works. This is a patient with a soft squamous cell carcinoma of the soft palate. He's a man of 65 years, and he presented with pain in his left throat and also otalgia on the left side. He has a normal intake, no weight loss. There's no significant comorbidity, but he is a heavy smoker and uses quite a lot of alcohol. And physical examination reveals a tumor of the left soft palate involving the uvula and also the anterior and posterior facial pillars. It's approaching the retromolar trigone and also involves the tonsillar area. Base of the tongue and posterior pharyngeal wall are uninvolved. And on palpation of the neck, there is a lymph node of 2 centimeters in level 2 on the left side. And as I said, the biopsy showed a moderately differentiated squamous cell carcinoma, HPV negative. Now, voting system works. In the left upper corner, you see a QR code. So if you take your smartphone and scan the QR code, you come in the voting system. So if you scan the code, then you will see on your phone the questions. And the question I would like to ask you is, what imaging would you order for this patient for assessment of the local regional extensions? Multiple answers are possible. You can choose either for a CT scan, MRI scan, PET scan, or ultrasound, or a combination of these. And of course, it's also dependent on whether you have access to these imaging modalities. It seems that the voting is working. I see that now 12 of you have given an answer, so it is working. I'll wait a little bit. It's counting here, and I think if I saw it correctly, we have about 60 participants. So we'll see. Wait a little bit. Try to get maybe some 40 answers from you, and then see what your policy is. Okay, 30 now. Okay. We're not yet at 40, but I think we can have a look at what your opinion is. Okay, so the majority of you, 85%, wants to do an MRI scan. A smaller proportion, about 1/4, a CT scan, and fewer will do a PET scan, and also a few persons do an ultrasound. It of course depends on, as I said, if you have access, for example, to PET scan, and I don't think all of you will be in that situation, but I very much agree with the MRI scan, which most of you chose, because I think that is the imaging tool that will give you most of the information. In my center, the policy is that we do an MRI scan for tumors above the hyoid, so that is oral cavity tumors and oropharynx tumors, because there you are mostly interested in the soft tissue extensions, whereas for tumors below the hyoid, we mostly choose for CT scan because there you are more interested in, for example, invasion in the thyroid cartilage. So this is the MRI scan of that patient. It confirms what we already saw on clinical examination, a tumor in the oropharynx on the left side. Here you see the extensions. It involves the uvula, the tonsillar area, the falcial pillars, and also it goes towards the retromolar trigone. To retropharyngeal lymph node. There are no very strict radiological criteria for you consider retropharyngeal lymph nodes as metastatic. Usually you don't see normal retropharyngeal lymph nodes on an MRI scan. And if they are enlarged, there is already quite a high likelihood that they are metastatic. In our center, we use an arbitrary cutoff level of largest diameter, larger than these 4 millimeters. We consider cytology, so for cytology, so you have to rely on imaging. Sometimes, if the nodes are large enough, PET scan can help you, of course. If they are positive on PET scan, of course, they are very likely to be metastatic. The lower image, oh, I'm sorry. The lower image is at a level of. So we see the tumor, we see bilateral retropharyngeal nodes, and we see a level 2 left neck node that is clearly too large, and also maybe there is a slightly necrotic center in this node. We did punctures of the neck nodes, several neck nodes, both on the right and the left side, but only the level 2 left node showed squamous cell carcinoma. So the next question is, what imaging do you order for assessment of distant metastasis? Do you think the risk so I don't need any assessment? Or do you say, well, at least I want to have an X-ray, chest X-ray, CT chest, CT abdomen, or maybe a PET scan if you have access to PET scan? I'll wait for a few moments for you to give your answers. Okay, let's have a look. Okay, so 2/3 of you say PET scan. So quite a good number of you have access to PET scan. That is very nice. A few fewer people say CT chest, most used screening tools for distant metastasis, as of course the primary organ for metastasis of most head and neck cancers are the lungs. So you want to concentrate on the lungs, but of course the PET scan has the advantage that it can screen the whole body. In my center, we normally do a CT of the chest for screening M status because, as I said, the first site for cancer is the lungs. And there's also a consideration of cost and capacity. So we normally choose for a CT chest, and in some other cases, in selected cases, we will also do a PET scan. Or as in our indications for a CT chest for screening M status is that we do it for T3 and T4 tumors. We also do it for patients with neck node metastasis if there are 2 or more, or if there is one node greater than 3 centimeters, or if there is contralateral or level 4 or 5B lymph nodes. Also, we do it in case of a recurrent tumor, or if the patient develops a second primary tumor in the head and neck, because then we think the patient is at increased risk of having other, in particular, smoking-associated tumors. So there could also be a second primary or maybe a third primary in the lungs. So this is our protocol for screening the M status. Now, suppose that the CT of the chest is negative. How will you stage this tumor? You have a lot of choices. So go ahead. As you could see on the MRI scan, the largest dimension of the tumor is 5 centimeters. As I mentioned, there are 2 slightly enlarged retropharyngeal lymph nodes, and there is a clearly metastatic lymph node in level 2 on the left. I see few votes. Can you still see me?
Yeah, we can see.
Yeah, Warren, yeah,
Yes,
see
yeah.
me.
Okay, very good. And as I said, this is a HPV negative tumor. As you may know, the new classification, TNM classification, HPV associated tumors and HPV negative tumors for the staging. The voting goes a little bit slow, but I think the reason is that you are, of course, not all head and neck specialists, and especially the latest classification system has become more complicated, especially with the distinction between HPV negative, HPV positive. So I have 23 votes now, so let's have a look what you choose. Okay. Actually, there we had a course we gave 2 years ago in Jakarta, and there also most of the participants chose for a T3 were the second. And here there's also a few persons choosing T3 and 2C. So it is quite, but most of you say T3 and 2B. Okay, let's have a look again at the images. Now, for oropharyngeal cancer, size is important for the T stage. If you have a tumor that is more than 4 centimeter in largest dimension, or if there is extension to the lingual surface of the epiglottis, it is a T3. T2 is between 2 and 4 centimeters. See on the MR scan, this tumor is more than 4 centimeters, so it is a T3. As I said, there's also bilateral slightly enlarged lymph nodes, and of course the staging depends on whether you consider these lymph nodes as pathologic. If you do, then you have bilateral lymph node metastasis, and then you would qualify it as a N2C, as we did. As I said, retrophylline nodes slightly enlarged have a relatively high risk of harboring metastasis. So, and also the site of these lymph nodes in relations for metastasis. So we staged it as N2C. If you go back, if you consider these retropharyngeal lymph nodes as pathologic, then you still have the clearly enlarged lymph node in level 2 on the left side, and that would classify it as N1. So T3 N1 or T3 I could agree with. T3 and 2B, as most of you chose, means multiple lymph nodes on one side. And I don't think you could opt for that option, because either you consider the bilateral retropharyngeal lymph nodes as positive, then it would be an N2C. If you consider them as negative, it would be N1. So it's either end. Is it surgery with or without post-operative radiotherapy? Is it radiotherapy alone? Is it chemoradiation? Or maybe radiotherapy plus cetuximab? Or do we want to recommend a more intensive treatment with neoadjuvant chemotherapy followed by chemoradiation? Okay, let's see. Majority says chemoradiation, but also about 1/3 recommend neoadjuvant chemotherapy and then chemoradiation. Oh, well, still people coming in with votes. Still the majority is chemoradiation. And about 20% say surgery and postoperative radiotherapy. And a smaller part of the participants say radiotherapy with cetuximab, and nobody chooses for radiotherapy alone. Okay, well, I think we may have an interesting discussion at the end of this talk. Second question is, if you choose radiotherapy or chemoradiotherapy, will you give elective neck treatment ipsilateral or bilateral? Okay, let's have a look. Majority says, and I agree with that. We chose, and the votes for radiotherapy alone was 0%. Actually, for this patient, we chose radiotherapy alone. Now, I agree with you that for stage 3 and stage 4 disease, and this patient classifies as stage 3-4, the recommendation and the guidelines say chemoradiation. Now, always we discuss with the patients, we give them a recommendation from our multidisciplinary conference, but we also discuss the alternatives. Now, as I said, the guideline says chemoradiation, but we discuss with the patient that this is although it is, we classified it as T3 and 2C, the tumor volume is relatively small. And we therefore discuss with him that radiotherapy alone is also a reasonable option. Chemotherapy adds some survival advantage, but it is modest. And of course, it also adds toxicity. So ultimately, this patient chose for radiotherapy alone. We gave him 68 gray in 34 fractions, tumor and pathological lymph nodes, including the retro lymph nodes. And we gave him 50 gray to the elective neck. On the left side, levels 2 to 5, and on the right side, levels 2 to 4. And we used an accelerated schedule, like the Hanka schedule, where you deliver 6 fractions per week instead of 5 fractions. So it is moderately accelerated, and that has demonstrated to improve the local regional control in the order of 10%. And this is the situation 3 months after completion of treatment. You can see some edema of the palate and the uvula here, but there is a complete regression of the tumor and also of the lymph node metastasis. And this is now several years after treatment, and the patient is still in good health. Now, to come back on your choice of chemoradiation, I think this is correct according to the guidelines, but be aware that the survival gain with concomitant chemoradiation is you will see more toxicity. And also, I think it is important to be aware of the fact that stage 3 and 4 disease is a very mixed bag. As you can see here, stage 1 is T1 and 0, stage 2 is T2 and 0, and all the rest is stage 3, stage 4. So a T1 and 1 tumor could already be a stage 3, but a T4B and 3 tumor is stage 4. But they both classify in the group stage 3, stage 4, for which these chemo radiation studies have these patients have been included. So it's a very heterogeneous group. So I think you could be a little bit critical and also take the tumor volume into account and weigh all these tumor characteristics and also, of course, the patient characteristic, condition, age, whether you give chemo radiation or not. This patient was relatively young, in good condition, but because the total tumor load was still relatively limited, we proposed radiotherapy alone. We did tell him that the standard, according to the guidelines, is chemoradiation, but we also gave him the opportunity to choose between these options, and he ultimately chose for radiotherapy alone. Now, another alternative could be to add cetuximab, and some of you chose for that. Now, there has been randomized trials comparing radiotherapy with cisplatin or cetuximab for HPV positive oropharynx cancer. So this is not for HPV negative tumors, as in this case. But the reason is that HPV positive oropharynx carcinoma seem to respond better on radiotherapy and chemotherapy. So the idea was that maybe we can cure these patients also with less intensive treatments and use cetuximab instead of cisplatin. However, the arm with cetuximab did worse in terms of survival as compared with the arm to cisplatin. So also for HPV positive tumors with good prognosis, cetuximab cannot replace cisplatin for survival outcome. But it may play a role for patients who, for some reason, do not tolerate cisplatin. This is a second randomized trial, which did the same comparison, but now for very low risk HPV-associated oropharynx cancers, and these were mostly non-smoking patients. But also there you see that they saw more recurrences in the patients that received cetuximab. Should we maybe do surgery? In the case of this particular patient, there was quite a large involvement of the soft palate, and it extended over the midline. Doing surgery would mean that you have to resect almost all of the soft palate. And this has severe consequences for the functionality. And a soft palate reconstruction is not very easy for surgeons to do. And usually also the functional outcome is not very good. And then patients, when they try to swallow, they get nasal regurgitation. So surgery in this case is, according to me and our surgeons also, not recommended because of a poor functional outcome. However, we do not have randomized trials between radiotherapy and surgery. This is a large survey across the USA and Canada of 51 retrospective series comparing surgery versus radiation therapy, or surgery with or without radiotherapy, or radiotherapy alone. And they showed for base of tongue carcinoma that the local regional control and also the survival was not different if you choose for surgery with or without postoperative radiotherapy, or if you choose for radiotherapy alone. And the same they found for tonsil carcinoma, no difference in local regional control and also no difference in 5-year survival. And you have to be aware of the fact that when you choose for primary surgery, in the majority of cases, especially in the more advanced tumors, you will need postoperative radiotherapy because rarely the surgery will be radical. And then you end up with a dual treatment, surgery and radiotherapy. And so the patients would then suffer from both the morbidity of surgery and the morbidity of radiotherapy. So therefore, the treatment strategy in the Netherlands is to choose for radiotherapy as first options, either or not with chemotherapy, depending on the stage of the tumor, because of a less morbidity instead of choosing for the combined modality. However, there are now new techniques for surgery, and the transoral robotic surgery is now very fashionable. Believe me, there is a patient somewhere in this picture, is somewhere over here, but you can see it is a very busy operating theater with many people involved. There, the experience with transoral resection is increasing, but there are little prospective studies and even fewer randomized studies. This is one randomized phase 2 study with a limited number of patients. 68 patients were randomly assigned to either radiotherapy alone or concurrent chemoradiotherapy, or transoral resection of the tumor and neck dissection first. But as you can see here, about 2/3 of the patient not only had surgery, but they also had postoperative radiotherapy and even postoperative chemotherapy. So in fact, this was trimodality treatment in these patients. So they analyzed the outcome, and it showed that the outcome is the same. There was no difference in overall survival with radiotherapy or chemoradiation therapy alone, or with surgery, and then in most cases followed by radiotherapy or chemoradiation. So the tumor outcome is not different with transoral surgery, but the quality of life was slightly worse in the surgical group, as you can see it here. And that is, of course, because these patients had also the morbidity of the surgery, and because the majority of the patients also had chemoradiation or radiotherapy alone, they had the combined modality of the dual or trimodality treatment. So although it is the use of robotic surgery is increasing, in my opinion, we cannot say that it is considered to be the standard of care at this point, because the outcome is not better compared to radiotherapy or chemoradiotherapy. The majority of the patients still need chemoradiotherapy or radiotherapy after the surgery, and it looks like it's more toxic, and also the quality of life is worse. So, in my opinion, transrobotic surgery at this point should only be done in clinical trials. But I do know that not all surgeons agree with me, and I do know, especially, for example, in the United States, but also in Europe, it's increasingly used, despite the fact that the evidence is quite low. A few words about ipsilateral or bilateral radiotherapy. There are a few important publications, and these are two of them. And they show that it is safe to do ipsilateral elective neck treatment if you have well lateralized tumors. And this is a paper from Princess Margaret Hospital in Toronto, and they recommend that you can do ipsilateral radiotherapy when the tumor does not extend more than 1 centimeter in the soft palate, and also not more than 1 centimeter in the base of the tongue. The patients can have ipsilateral nodal disease as long as it is N1 or N2A, so that means a single ipsilateral lymph node, and maybe also in N2B disease, so that means multiple ipsilateral lymph nodes. In those cases, if you treat the neck ipsilateral, the risk of recurrence in the contralateral neck side is very low, below 5 centimeters. And they show this also here, where they have very good regional control, both in HPV positive and in HPV negative patients. And for the patients that received ipsilateral treatment, you can see the regional control is very high, also in the contralateral neck. So it is safe to do ipsilateral neck treatment in selected cases. This is our institutional protocol. If we are a little bit more liberal than Princess Margaret, if you have a lateralized tumor in your oropharynx and it is invading less than 1 centimeter in the base of tongue, or if it is at least 1 centimeter away from the midline, we give ipsilateral neck treatment. Finally, a few new developments, and one issue that has a lot of attention in clinical research, and we see now coming several publications about this issue that address the question if we can reduce dose in HPV-positive tumors. This is just one publication. It is a recent publication from Memorial Sloan Kettering Hospital, where they did evaluation during the radiotherapy with PET scan. They did an FDG PET scan, but also an F-MISO PET scan at the start, before radiotherapy, and after 1 or 2 weeks during the course of radiotherapy. And then, if they saw a good reduction of hypoxia, because F-MISO is a tracer for tumor hypoxia, if they saw a good reduction of hypoxia, if there was no hypoxia at all, they gave only 30 gray total dose. Whereas if there was insufficient reduction of hypoxia, they give the full dose of 70 gray. Now, the design was as follows. They included 152 patients. They did first surgery for the primary tumor, either with transoral resection or open surgery, but they did not treat the neck nodes. And then the patient received postoperative chemoradiation. And they did the hypoxic PET scan at baseline and during the second week of the treatment. Now, of the 152 patients, 128 had no hypoxia in the neck nodes or had a good reduction of hypoxia in the neck nodes. And so these patients only received 30 gray to the macroscopic tumor in total. And the other ones that did not respond well received the full 70 gray. And they have a remarkable good outcome. The progression-free survival, also for the tumors that had a low dose of only 30 gray, had very good progression-free survival, and even an overall survival of 100%. None of these patients died during the follow-up, and it was a pretty good follow-up, with the majority of the patients having at least 2 years of follow-up. So this is a remarkable observation. Patients with very low dose of only 30 gray with macroscopic seem to be cured in the majority of cases with only 30 gray. And this is, I stress that, was only for HPV positive cases. And also these patients retained a very good swallowing function. As you can see, the majority had normal swallowing function, and some had only mild dysfunction. So this is a very promising study. I don't think you can do this already as a standard procedure, but it is definitely an observation that needs a follow-up in additional studies, and is a very good indication that we probably in the future can treat oropharynx carcinoma with lower doses. Another new issue is HPV DNA during radiotherapy and after radiotherapy. You can determine HPV DNA in patient saliva and also in patient plasma. And this can be a biomarker for response and possibly also an indicator for tumor recurrence. And this is a study where they determined HPV DNA in saliva of patients that were undergoing radiotherapy for HPV-related oropharynx carcinoma. And this is during radiotherapy, and these are the visits during and shortly after of radiotherapy. And what they see is a very nice decline of HPV DNA in the saliva of these patients during the course of radiotherapy, suggesting a good response to the treatment. They also looked at DNA in saliva after completion of treatment, and they saw that the patients that had persistent HPV DNA in saliva detectable during follow-up had more likely a tumor recurrence than the ones who did not have persistent DNA detectable. So possibly it can be a biomarker for recurrence detection during follow-up of these patients. This is a second very recent study. It was published this year. They show the same. This was HPV DNA not in saliva, but in plasma. And they also followed patients with plasma DNA detection during follow-up. And also they show a very strong association that patients with no detectable DNA in plasma during follow-up had a very low risk of recurrence, whereas the patients who presented with detectable DNA did significantly worse, and indeed very worse. But if you look into the details of this study, it is important to notice that the recurrence rate, as you might expect for HPV-positive oropharynx carcinoma, is low. In this cohort of 155 patients, only 15 developed a recurrence. And of these 15, there were 6 patients HPV DNA in the plasma before the recurrence was detected clinically or by imaging. And of these 6 patients, 4 presented with distant metastasis. 5 other of these 15 patients had also a detectable DNA in the plasma, but more or less at the same time, the tumor recurrence was already detectable also clinically, either by physical examination or by imaging. So in fact, the detectable DNA did not add much in the time frame for detecting the tumor. Then there were also 4 cases that developed a recurrence, but were false negative DNA with undetectable DNA in the plasma. So despite the fact that there was no DNA in plasma, they did develop a recurrence. And finally, there were 3 patients with false positive results. So they did have detectable DNA, but they did not, at least not yet, develop a recurrence after respectively 14, 18, and 28 months. So although it seems to be a nice biomarker, if you look in more detail, in fact, only in 2 cases the DNA, the plasma DNA, the early detection could have some impact on the treatment on the treatment strategy and outcome of the patients, because of the 6, 4 had distant metastasis, which very likely were not curable anymore, and only 2 had an early detection of a local regional recurrence that was not obvious on physical exam or imaging. Okay, I think it is in the Netherlands is 11:15, so this is 5 quarters. I have some results of our own studies, but I think I will stop here because it would be nice also to have some time for you. So please go ahead. I don't know if there are any questions in the chat box, and maybe the members from the panel would add some comments. So I give the word back to you.
Okay, thank you, Prof. Kanders, for the very interactive, informative, and comprehensive presentation. Now, I'd like to open the floor to our panelists, to their comments and perspective on the topic. For the first opportunity, maybe for Dr. Wigati, would you please share your thought, experience, or question about the topic?
Good afternoon, Prof. Kanders.
Hi.
Hi. Nice to meet you again. In this small. Thank you for your presentation, for your nice presentation and interesting. Maybe I want to because of this your case in here. I want to know how about if there is a long waiting list for the patient, and then the first time it's neoadjuvant chemo, and then following for chemoradiation. How about this?
Yes.
For your opinion.
Yeah.
Yes.
I saw that several of you chose this option,
Yes.
neoadjuvant chemotherapy and then followed by radiotherapy alone or chemoradiation. There is no good evidence that
Yes.
chemoradiation, neoadjuvant chemotherapy adds a benefit to chemo. There are some indications, but there are not good randomized trials. So that's the reason why we don't do it. But you say, yes, but if we have long waiting list for the radiotherapy, we want to do something at least to slow the progression of the tumor and maybe have already some tumor regression. And in this situation, is an option because of the situation and your in case you have limited capacity for radiotherapy. So then I can understand, and I don't think it. I think it is a reasonable solution. Of course, you would like to start the radiotherapy as soon as you can, but
Yes.
I also understand the situation in your country, and the capacity of radiotherapy is still not as it should be. So I do understand, and I agree with you that in those cases it's a reasonable option. If your capacity of radiotherapy is sufficient, I would not do it. But in your situation, I can agree.
Okay, thank you. Well, and then interesting for torch, yes. Apa tadi? Katakan apa torch tadi ya? TOLS robotic. And how about in Netherlands? It is available to me, but your opinion is not.
Yes. Well, my opinion is not always the opinion of the head and neck surgeons, but in the Netherlands, we have 2 centers that do transoral robotic surgery.
Yes.
One center is not doing many malignant diseases. They use transoral robotic surgery mostly for benign diseases or for a pleomorphic adenoma. The other center in Amsterdam is doing it for oropharynx carcinomas, but only in very selected cases. So most of the head and neck centers in the Netherlands do not use transoral robotic surgery. Well, actually, for the reasons I explained, that although some head and neck surgeons do like the technique, but they also see that in limited cases, you can really achieve a radical resection margin, preferably also without neck disease, that it can be beneficial. But the benefit, you lose most of the benefit if you end up with positive margins and you still have to give radiotherapy or chemoradiotherapy. Then you lose most of the benefit, and most of our head and neck surgeons agree to that. So so far, here in Netherlands, we do very little transoral surgery. Most centers do it not.
Most centers can do the TOS or
No, most centers not.
no more? Oh, yes.
No.
Okay.
No.
Yes. And the last question from me is how about use for happy HPV positive and then clear 30 days for and then chemoradiation or
But
for HPV?
for HPV positive,
Yes. Yes.
your question is if you give neoadjuvant chemotherapy, or what is it?
The dose.
The
lower
dose.
dose. Yes, the dose.
Okay, the radiotherapy dose, you mean?
Yes. Yes.
Oh,
Okay.
yeah. So at this point, we treat the HPV positive oropharynx carcinomas with the same dose as the HPV negative tumors. Now, as I said, there are already studies that show that a lower dose for the HPV positive tumors may be as good. And very impressive, this study from the United States, where they only give 30 gray in the non-hypoxic tumors, of course, is very impressive, because that's a very strong, very large reduction of the dose.
Dose of radiotherapy. Yes.
And there are also some other studies that show that, but at this point, we don't have good randomized trials yet. The trials are ongoing,
Yes.
and we must wait for the results. But I expect results, and my expectation is that the lower dose is as good as the higher dose, and hopefully in a few years we can reduce dose for the HPV positive tumors, and that would be, of course, that would make a lot of difference in the toxicity.
Okay, thank you. And then I want to give to Dr. Says again. Thank you very much. Nice.
Thank
You're
you, Dr.
welcome.
Wigat. Yeah. Okay, maybe the next opportunity for Dr. Henry Kodrat. Maybe you have any comment or maybe question to Prof. Candace. Please, Dr. Henry.
Thank you, Dr. Caesar. Okay, maybe I will give some perspective from the Indonesian. So in Indonesia, most of us do with CT scan, but right now for the imaging, for the academic hospital, we have start with the MRI. And I'm totally agree with Professor Kanders for above the hyoid, we do MRI. And the second is about the staging. So I'm very glad that you mentioned only do with the chest CT scan. In Indonesia right now, many centers do with the chest X-ray, or for the private patient, we do with PET scan. But I'm glad in Netherlands you do with the chest CAT scan. Why? Because you do the most beneficial thing. You only do the staging for the most common metastatic lesions, and then this patient has a smoking behavior. So I think CT scan for the chest is very good. And then for the doctor, we get the questions about the induction chemo. Actually, I do not agree with induction chemo in oropharyngeal cancer. So maybe I can give some suggestion that we do some hypofractionation. If there is some long waiting list, we can do some hypofractionation for breast, for prostate, for the palliative. But the oropharyngeal cancer, I have to give chemoradiation. There is no benefit for the induction chemotherapy. And for the head and neck, I think induction only gives some advantage in the nasopharyngeal cancer and maybe in laryngeal cancer, but not in oropharyngeal cancer. And then I think for Indonesia, I think we still need to wait about the reduced dose, because I think we need a long follow-up. There is some issue about follow-up in our country. But I have a question for Professor Kanders. I think in your presentations, you include level 5 in the left side, but you do not include level 1B. In MRI, there is some improvement in the retromolar triangle. My question, why do you not include the level 1B? And for level 5, I think if the only small lymph node in level 2, I will not include level 5. And the other thing that I very glad to hear is about the tumor volume. I'm very understand that in Indonesia, the common practice, they always include only TNM, and sometimes they include the stratification, for example, HPV, smoking, like in the Tianang normogram. But I'm very glad that the tumor volume in the future, it will one of the most important prognostic factor. Because for the low volume tumor, I think we do not need to give aggressive treatment. I think that's my opinion. Thank you so much.
Okay. Well, yeah, thank you very much for your comments. Your question about the level 1B, I think is a very good one, because I remember that in this patient, we discussed a lot about this. And so it's good that you bring up this question, because indeed, when the tumor grows into the oral cavity, we do include level 1B. And so in this particular case, we had discussion, well, is it already in the retromolar trigone, or is it just approaching the retromolar trigone? So it was really a bit on the edge. Some, because all of our patients we discuss in our daily clinic with all the staff of the department, and some were proposing including level 1B, and some were proposing not to include level 1B. So, but it's a very good point, and if the tumor would really have grown in the retromolar trigone, we would certainly include level 1B. So it was a little bit on the edge, but I agree totally with you. If the tumor is confined to the oropharynx and does not grow into the oral cavity, the risk of level 1B involvement is very low, and there are a few publications that have demonstrated that. About level 5, I agree with you that with one lymph node level 2A, the risk of level 5 involvement is fairly low. On the other hand, the toxicity that you add by including level 5 in the elective volume is also not very much. You don't add a lot of toxicity in that. So that's also a balance that we weigh. Alternatively, if you include level 1B, then you do add more toxicity. So one thing is the risk of involvement of a certain lymph node level, and the other side of the coin is what morbidity do you add. So we try to weigh these two things against each other. So that is why we chose to include level 5, although the risk there is low, but also because it adds little toxicity. And we chose to avoid level 1B because the risk there is also relatively low, but including that would add more morbidity. So what was your other question? I forgot, I'm sorry.
Okay, I think you already answered, but I have more questions. Is about your policy in Nijmegen. How do you treat about perineural invasions in head and neck cancer?
Okay. So this is in a post-operative situation, mostly. Perineural invasion for us is an intermediate risk factor, but if it is in combination with a second intermediate risk factor, we gave post-operative radiotherapy. And for perineural invasion, we always take generous margins, and we make a distinction between perineural invasion of small nerve fibers or large named nerves. Like, for example, if clearly let's say the lingual nerve is involved in a carcinoma of the tongue, then we take into our target volume the whole trajectory of the nerve up to the base of the skull, because we know that the tumor can travel over long distances along these large nerves. So then we take very generous margins. But also if it is in smaller nerve fibers, we include margins of at least 1.5 to 2 centimeter in the trajectory of the nerve. to be certain that we have a generous coverage of the tumor extensions.
Okay, so in your center, you only give 1.5 up to 2 centimeters. Is that correct?
For if the perineural invasion is a small nerve involving a large named nerve, so like the mandibular nerve or the lingual nerve, then we treat all the way up to the base of the skull.
Okay. Okay, maybe in my last comment, I comment about the tumor volume. Tumor volume, yeah.
Ah, yes.
Yeah,
that was
I
it.
think that's a good prognostic factor. My question is,
Yes.
how big the influence the tumor volume for the treatment decisions or about the prognostic factor, in your opinion?
Well, this of course only comes from retrospective analysis, and there are several studies that show that tumor volume is a prognostic factor, and that is of course logical. The bigger the tumor, the more difficult it is to treat. But the case I showed, for example, you can have, especially tumors of the soft palate, they can be fairly superficial, but they can extend over a large area of the mucosa. So they can have a larger dimension, more than 4 centimeters, but still be very superficial. But if it's more than 4 centimeters, it's already a T3. And in those cases, we think that giving then chemo radiotherapy, because it's a T3, is over-treatment, because still you are treating a very superficial tumor. So in that case, we let the volume play a role. We don't have very strict cutoff levels of certain volume that we give below a certain volume, we give only radiotherapy, and above other variation. We don't have really good data to make, so we decided on an individual base. But a standard that every stage 3 tumor should receive chemoradiation because of the stage. As I said, you could also have a T1 N1 tumor, which is T3, and it could be maybe a very small on tonsillar cancer tumor, maybe centimeters, and you have a small lymph node, 1.5 centimeters, so it's T1 N1. We don't really see a reason why we should treat that with chemo. I think we could do very well with therapy alone.
Seconders, maybe we will let the audience to give some question or comments. Thank you so much.
Thank you very much, Dr. Henry. Maybe we will move to the question from the participants and check the chat box.
May I have one question?
Okay, please.
Yeah. Thank you
Dr.
very
Rizal.
much,
Yeah, please.
Professor, for your excellent presentation. One question for me, maybe in the beyond of the topic, how do you think about using a proton for the oropharyngeal cancer? Because maybe Indonesia, for the few years to go, will have the machine. Thank you very much.
Okay. Yes, protons. We have protons in the Netherlands, and we work what we call a plan-based comparison to decide whether a patient qualifies for protons or not. So we compare the photon plan with the proton plan, and then we look at the anticipated NTCP for swallowing and xerostomia, and if there is a certain difference large enough in favor of protons, so if protons can make a significant improvement at NTCP, then the patient can have proton therapy. So this is all model-based, and unfortunately, we still don't have randomized trials that really do show the benefit of protons. There is now one study completed in the United States from MD Anderson. It is not yet published, and they showed that patients treated with proton therapy have a better survival, but not better local regional control, and not better disease-free survival. So it is a little bit, the question is, why do these patients have better survival, whereas the local regional tumor control or the disease-free survival was not better? Were there maybe other factors playing a role here? But I only know this from a very short presentation, so we have to wait for the publication to see what really are the results of this trial. So, but the bottom line is, so far we don't have good randomized trials that show the benefit of protons. Protons are also quite expensive, and so especially if you are if you are short in capacity for radiotherapy, I think I would use the proton machine very selectively for, like, for children, for example, for skull brain tumors. At this point, we do send some patients, head and neck patients, for protons, but personally, I really would like to see first good trial results before we choose to elect to send many patients for proton therapy. I think the evidence at this point still is very low, and we also don't know really still very good what the benefit is in terms of reduced toxicity.
Thank you very much, Professor.
Okay, thank you, Dr. Defrizal. I think maybe that's the last question, Prof, because the time, maybe I will close this webinar. We extend our deepest appreciation to our speaker and for our panelists, Dr. Wigati and Dr. Henry, for their excellent presentation, and to all participants for the attention and engagement. We look forward to welcoming you to our next webinar. Thank you and have a pleasant day. Thank you very much, Prof. Dr. Henry, Dr. Wigati. Yeah.
Thank you for
Thank
the
you so much.
invitation. Thank you. Bye-bye.
Bye-bye.
Bye.
Thank you. Bye-bye.
Thank you. Bye-bye. Thank you, Judy. Bye-bye, Judy.
Bye.
Bye.
Judy.
See
Bye,
you.
Judy.